So I will speak about round versus anatomical implants in breast reconstruction, and I would like to dedicate this talk to my late friend, Scott Spear. Scott said we want to encourage the patient to let us perform their reconstruction and yet seriously warn them why they should not go ahead with it. I confess, Scott said, that I'm much more enthusiastic when explaining the great advantages of breast reconstruction and the possibility of an attractive result than I am when describing the long list of complications. I, 2 years ago, made a selfie iPhone study asking plastic surgeons around the world what is their preferred implant, round or anatomic or smooth and textured. And this was about smooth and textured. Can you click on the video, please? Vous pouvez cliquer sur la vidéo, s'il vous plaît? Merci. We need the sound. Il y a du son. Ah. Vous avez le son? Anyhow, now, est-ce qu'il y a du son ou pas? Because this is fun. I was actually surprised when I got the results of that because 50% of the people around the world and people that I appreciate very much said smooth implants and smooth is round. So that made me thinking, est-ce qu'on a le son avec la vidéo ou pas? Non, ça marche pas? Okay, bon. Let's give it up.
Textured Sientra implants.
Texture.
Textured.
Smooth.
Smooth.
Textured.
Smooth.
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 Textured, of course.
Bon, so what do we think we know? We know that textured implants are more popular than smooth. Certainly in Europe, textured implants disrupt the alignment of tissues in a way that they have a lower capsular contracture rate, especially in the pre-pectoral position. Textured surface topography is generated randomly, but textured surfaces may be associated with other problems than capsule contracture. Ça bouge pas. What do we know about capsular contracture? It's one of the most frequent and frustrating complications of implant-based breast surgery. The principal etiology is blood and fluid and low-grade infection and biofilm in the pocket around the implant. What is the true incidence of capsule contracture? I don't think we know this with precision, but I do think that it's lower than seen in the Allergan Mentor studies, which likely represent the upper bounds of the rates of capsule contracture, as the surgery for those patients occurred about more than 15 years ago, and surgical techniques have changed over time. In our most recent publication in January in PRS, the incidence of capsule contracture in breast reconstruction with ADM was 2.7%. Are bacteria always involved with capsule contracture? Well, the best available science shows that there is involvement in the vast majority of patients with capsule contracture, and that the type of bacteria most associated with capsule contracture is gram-negative Staph aureus bacteria, skin bacteria. This is an article by Rod Rorich about a year and a half ago about looking at all the things you can do once you have an established capsule contracture. And basically, side change and implant exchange are associated with reduced capsule contracture once you do that. And they play a serious role in reducing a second time capsule contracture. Interestingly, and we've known that for years now, that the ADM in breast reconstruction provides you with a protection against capsule contracture, and that's why acellular dermal matrix, both in aesthetic cases with recurrent capsule contracture, may play a role. Do capsule contracture and ALCL share a common pathway? We're not sure, but best available evidence, we can ask Mark here, support the role of inflammation in both, but distinct different pathways. The other thing is that the bacteria associated with ALCL are usually gram-negative bacteria as opposed to what we've seen in capsule contracture. Do smooth and texture implants under the muscle have a different capsule contracture rate? The best available evidence support no significant difference when under the muscle, but typically a significant lower incidence of capsule contracture if textured in a subglandular plane. This too has been put to question in recent years with the introduction of new nanotextured surfaces, and we have to see, and as more surgeons in both reconstruction and aesthetic surgery are going into smooth, round, over the muscle or under the fascia, this will be challenged in the next couple of years, I believe. Do smooth and round implants have worse outcomes in breast reconstruction? This is an article published last year, and the results of overall 822 patients that had round and 297 patients who had shaped implant, patients undergoing unilateral reconstruction with round implants underwent more contralateral procedures, including augmentation. So what does that mean? What this article showed is that in a very large group of patients, both patients and surgeons show no difference or no preference to either round or anatomical implants in breast reconstruction. If you look at bacteria relatively to the aggressivity of the texture, you can see that the more aggressive the texture is, the more number of bacteria you can find on the surface of the implant. And now that we know that bacteria are associated with both capsule contracture and ALCL, we should think about it one more time. Recently, 2 weeks ago in New York, Anand Diva suggested to put a grade on the surfaces with a polyurethane, the most aggressive textured being grade 4 surface, with the biocell of Allergan being grade 3, and then Mentor Siltex being grade 2, and smooth Mentor, Allergan, and Motiva being grade 1 surface. So the factors to consider choosing between round and anatomically shaped implants in breast reconstruction are the feel and appearance in vivo, the durability of the implant, the safety and risk complications early and late, revision and reoperation rate both, patient preference, selection range, and cost. The Allergan 10-year study showed a higher incidence of capsule contracture with round implant, but a higher rupture rate with the 410 implants. If we look at the Mentor 10-year study, we see that the capsule contracture rate on secondary augmentation is 15.6, and the MRI rupture is 9.9. Assuming the reconstruction data is generally worse than the augmentation data, this suggests a high capsule contracture rate and rupture occurrence, which is not so true because with the use of ADM, the incidence of capsule contracture in breast reconstruction is lower than most of reported capsule contracture in breast augmentation. So we also know that with shaped implant, you have a rotational deformity, and we know in some studies it was up to 14%. The advantages and disadvantages of Mentor, for a second, are lower capsule contracture rate, possibly lower revision rate, more IMF than subpectoral, adjustable in 3 dimensions, so you have a lot of choices. You can choose the width, the height, and the projection. They're somewhat less deformable, and if you look at the disadvantage of those, you can see that there's a rotational risk, there are fewer options, they're roundish, they're firmer, they're more expensive, more late seroma, and possibly more ALCL. The advantages and disadvantages of round implants are there's lots of choices, no rotation risk, fewer ruptures with a smoother textured, it's not moving, different gel options, softer gel, more natural, mobile, smooth, have less seroma and ALCL risk, and the disadvantages are those. So, with that, I want to conclude with 2 slides. One summarized by Anand Diva 2 weeks ago, setting of antigen-derived inflammation, genetics, bacteria, textured implants, and time form the 4 factors that weave together in the unifying hypothesis put forward to explain the likely genesis of BIALCL. As of now, we have 2 modifiable targets to potentially reduce the risk of this cancer, our choice of implants and the way we handle the antimicrobial situation during surgery. Scott Spear put a selection of grading that he graded different implants and gave them numbers from 1 to 10. And he gave the overall smooth round implant an 87% and the overall 410 implants 80%, so it's slightly higher. When do I prefer round, smooth implants for breast reconstruction? For bilateral reconstruction, for nipple-sparing mastectomy with sufficient loose skin, for women who want to accept more extra upper pole fullness, roundness, and emptiness, and for women who want their breasts somewhat mobile. My current practice is my default option for routine bilateral breast reconstruction is a smooth, round silicone implant. I reserve textured shaped implants for unilateral cases, radiated breast, major asymmetry, and women who demand shaped implants. Thank you very much.
Okay, thank you, Michael.